Hello, everyone, and welcome to the HHQI Cardiovascular Learning Action Network, or the Cardio LAN. It's December 2014, and this is our monthly meeting of coming together of all the cardiovascular improving folks in the country, and we want to welcome everyone, whether you're listening to the archived recording or whether you're participating in the live event. We thank you for taking the time out of your day to join us, and we hope that you'll be able to take a few pieces of information to your clinical practice once we finish this webinar. So with us on the call today, we have the HHQI team, which consists of Stacy Deslick, who is a health data analyst. We have Misty Kevich, Crystal Welch, and myself, for those of you I haven't met. My name is Cindy Sun. We are the 3 RM project coordinators for HHQI. And we're very excited to be here today, and we're excited that you're joining us. With us also today, we have Rita Grimes representing Qualidigm, and I'll formally introduce you to her in just a few minutes. She is our special guest speaker today, and we're very pleased to have her. Just a few housekeeping things before we get started. As I've mentioned, this is being recorded, and it's recorded because, as we all know, sometimes our schedules don't quite work out to where we want to join something and we're not able to. So it is recorded on the website. All lines are currently muted. This is my impersonation of someone begging, please take a moment if you don't mind and mute your own lines. The only thing worse than us eavesdropping in on your conversation is to eavesdrop and broadcast that private conversation at a national level and then record it for posterity. So please just take a moment and mute your own line. We will be unmuting the lines later on in the call for a little Q&A. So the way the call is going to work today, the agenda will go, as I mentioned, Rita will be along to present HHCAHPS and the cardiovascular care in the home using data to improve patient experience of care, followed by Misty Kevich, RN Project Coordinator. She's going to talk a little bit about tools and resources that are currently available to help move this HHCAHPS information into the practice setting. She'll be followed by Crystal Welch stopping by just to provide a few campaign updates, because one of the benefits of participating in this informal work group is to be one of the first people to hear of upcoming HHQI events. So if there's an event that's upcoming and interesting to you, you can get in and register before it meets its capacity. And then finally, we're going to introduce a new section called Stacy's Corner. That's what we're informally calling it. And then Stacy Deslick will be along to talk about the Home Health Cardiovascular Data Registry with some fun facts and interesting tidbits, such as what agency was the first agency to close out their month in November? Who actually was the first agency to close out all 4 of the ABCSs? What was the most popular measure that was abstracted? So those types of things. Stacy will be along to share with us after that. And then we'll open up all of the lines for Q&A and get to as many questions as we can on the call today. So at this time, I'd like to introduce you formally to Rita Grimes. Many of you know her already, but in case you haven't, you can see her credentials are on the screen. And Rita is a consultant for home health care at Qualidigm. She serves as project manager, the lead for home health consulting contracts, an educator and trainer, and is a key resource for home health administration and quality improvement, staff in data analysis, data abstraction, compliance, and quality improvement. Rita has over 30 years professional nursing experience and practiced in both the U.S. and in Canada in outpost, emergency, critical care, and community nursing. Prior to joining Qualidigm, Rita worked as Vice President of Performance and Quality Improvement, leading teams whose work resulted in the reduction of hospitalization rates and excellence in coding and review practice. She managed the implementation of best practices for wound care, medication management, pain, and depression screenings in agencies. She directed and led the Health Information Management, or the HIM department, to ensure record accuracy, access, and confidentiality. Rita has also coordinated and led educational presentations on OASIS and depression screening and interventions at the Connecticut Association for Home Care at Home. She continues to work with UConn researchers to ensure proficiency in standardized depression screening. Rita continues to train providers in the home health, physicians' practices, hospital-based case management, and outpatient clinics on chronic care management and transitions of care. Rita is an active member and a number of professional organizations, including National Quality Institute, Healthcare Compliance Association, American Nurses Association, American Health Information Management Association. And finally, Rita holds an MSN from the University of Hartford and earned her BSN in the University of Victoria in Victoria, British Columbia, Canada. She is licensed as an RN and certified in diagnosing coding, OASIS, chronic care management, and is a certified CHAHPS consultant. So with this, we'd like to welcome Rita, and with that, Rita, I will turn it over to you.
Thank you, Cindy, for that introduction. I'm delighted to be here to talk with all of you about patients' experience of care and its significance in chronic care management. So our objectives for today are to describe the collection process of HHCAHPS, operationalize an HHCAHPS improvement plan, and to align specific areas of need with implementation of preventative cardiovascular care. Next slide. You know, whenever I think about a problem or a situation in home health, I attempt to stick closely to our mandate from the Office of Management and Budget and the National Quality Forum, and that is to provide care that is safe, timely, effective, efficient, equitable, and person-centered. I find that using an acronym STEEP to frame the situation works well in all care and agency decisions. So, for example, at care decision points, clinicians will often step back after developing their plan of care and ask, you know, is this care plan that was developed collectively safe, timely, effective, efficient, equitable, and person-centered? I also find on the agency level, your administrator, when making decisions, will step back and ask, do policies, procedures, staffing, and programming allow for the care teams to provide STEEP care? We know that person-centered care is critical to effective disease management. It essentially is the provision of safe, effective, and timely care, but through the cooperation among the physician and an informed and respected patient and family, as well as the whole cadre of healthcare team members. We also know that person-centered care fundamentally requires patient engagement at every step of the care process and at every step in effectively managing the disease process. As we know, that critical to patient engagement is good communication. So we in the industry have worked to really hone our communication skills, to really practice our listening, and really learning from patients and families and the care team. Good communication can inform your team about the patient's goals of care, any obstacles to achieving self-care, and that's really fundamental to increase both the patient's confidence in managing their complex disease process and also the care team. HHCAHPS data allows us to view the patient's experience of care through the eyes of family, patients, and truly does inform our practice. The key here is to effective disease management, is to really require care providers to view all care experiences through patient and family eyes. Next screen. So HHCAHPS survey was developed through a research process by the Agency for Healthcare Research and Quality, and it's endorsed by the National Quality Forum. Reporting HHCAHPS is required for participation in Medicare and Medicaid programs since 2012, and those agencies who did not comply with the requirement for reporting saw a 2% reduction in annual payment update reimbursement rates. And it is anticipated to be a major factor in a performance-based reimbursement system. Next slide, please. So we know there are 5 measures, 2 global, 3 composite, And we know that there is a risk adjustment for differences in case mix across agencies. The survey itself is available on the HHCAHPS website in 5 languages and can be easily downloaded. Next slide. So Medicare certified agencies are required to contract with an approved survey vendor. A listing of approved vendors can be accessed on the website you see on your screen. The listing you see indicates that the vendors have met all requirements for conducting a survey. So do visit that site. Next screen. Current reporting on the HHCAHPS website reflects the data collected for 4 quarters between April 2013 through March 2014. So this data collection period is over. However, the period reflects current reporting that is publicly available. Next screen. We are currently in the 2016 data collection period that began in April 2014 and will run through March 2015. Next screen. There are 2 exceptions to the reporting requirement. The first exception relates to when you became Medicare certified. So if you were not certified throughout the entire data collection period of April 1st, 2013 to March 31st, 2014, you are exempt from reporting. Though you're exempt, I will mention that you're likely collecting some data about the number of eligible cases in order to prepare for the next phase of reporting. Next screen. The second exception relates to the number of eligible cases. So, for example, if you were Medicare certified for the entire data collection period and you had fewer than 60 eligible unduplicated patients, so 59 or fewer, with the same in the same data collection period, then you are exempt from reporting. However, you absolutely must submit a participation exemption request form from the HHCAHPS data collection and submission requirements. The form can be found on the website listed on your screen. Just a caveat that CMS is firm on the deadline for filing an exemption. So for the fiscal year 2016, the current period, you must file an exemption request by March 31st, 2015. Next screen, please. So vendors can provide some very valuable feedback on some questions. And it truly does help you if you know in real time responses to questions, any issues or concerns that may have arisen. If respondents indicate that they would like to be contacted, you're able to reach out to patients to further explore any issues involved with their care. Additionally, some vendors are able to cross-reference OASIS data with composite measures. So just as an example, the composite measures specific care issues may talk about, have you talked about medications, can be referenced in the OASIS process measures. Any inconsistencies can be vetted out to explore, for example, whether teaching approaches were adequate and met the needs of the patient. Next slide, please. So just quickly, we're going to go over the measures and what we're currently seeing posted for national averages on the Home Health Compare website. So the first measure, global measures, is overall rating of care. These are patients who gave their home health agency a rating of 9 or 10 on a scale of 0 to 10. This involves question number 20 of the HHCAHPS survey, and the national average is currently 84%, and that's for the data collection period April 2013 to March 2014. Next slide. The next global measure is likelihood of recommending. These are patients who reported yes, they would definitely recommend the home health agency to friends or family. One question from the survey, and that's question number 25. And the national average currently is 79%. Next slide, please. A composite measure called care of patient. These are patients who reported that their home health team gave care in a professional way. Now, you can see on the screen, Medicare did define what is professional way, and that is problems. There were no problems with home health care. The patient felt providers were always gentle, always respectful, and always up to date on patients' treatment. This involves 4 questions, number 9, 16, 19, and 24. Current average is 88%. Next slide, please. The next composite measure is communication. And these are patients who reported that their home health team communicated well with them. CMS has defined communicated well as meaning that we explained services before giving the services, that we gave advice promptly, that we always said when staff would arrive, we always explained things clearly, and we always listened carefully. This is a tall order. These questions are coming from number 2, 15, 17, 18, 22, and 23. The national average is currently 85%. Next slide, please. Special care items is the next composite measure, and those are patients who reported that their home health team discussed medicines, pain, and home safety with them. This is a challenge for many agencies, especially in the area of teaching to side effects, pain, et cetera, can be very, very challenging. The questions involved here are 3, 4, 5, 10, 12, 13, and 14, and the national average currently is 84%. Next slide, please. So this is where we get into the good stuff, okay? So how do we approach ratings that were either did not meet the agency threshold for improvement or did not meet the national averages? That's your benchmark. So let's take a look first at your operations. If your measures are not comparing well, these are just some examples of those agencies who do perform well. So, for example, ask, do you have a designated HHCAHPS champion? This is typically the person that most often is recognized as the face of patient experience of care. They may be the person who brings the information to employees and to partners about the patient's experience. They may be the person who posts the HHCAHPS results or reports firsthand what they're hearing in the field. These are often people who patrol the block, so to speak, talking with providers and patients, listening, seeing, and experiencing provider communication styles, communication among patient schedulers, and these are people who are aware of challenges to communication in the home environment. So ask yourself, do you also have procedures for check-in? Now, check-in is just a simple, basic tool. It's based on principle that by checking in before any engagement, that you set the foundation for patient, family, and provider interactions. Check-in can help on, common appreciation of where everyone is in that particular day before you then engage in your teaching or addressing specific larger objectives of care. So, for example, it might look like this. Know what's important to the patient by routinely asking, so what's important to you now in this moment, or what are your current concerns, or what is your greatest concern? We know that unless we're able to take care and clear the slate with any anxiety or stressful situation that we're unable to proceed any further with any care objectives. Also, it's good to check in a telephone triage manner. So many agencies do cold calls to existing patients and families within the care episode, so they can determine whether there's adjustments to care that are needed. And I'll mention again, it really is imperative to have a SMART goal, and this is really specific, measurable goal based on the patient's objectives for care. So knowing what the patient wants out of his or her episode is really a step toward patient engagement and is critical to overarching objective of how to achieve self-management. Check-in can quickly establish what's important or pressing for the patient or family. Next slide. Next slide, please. Thank you. So many successful agencies have incorporated very powerful procedures and techniques to inform them about patients' experience. I've seen firsthand clinicians who really lack confidence in using some of those motivational interviewing techniques, largely because they have not practiced motivational interviewing. So we find that it's critical to establishing effective communication, building provider confidence, and as well as patient engagement. Ultimately, that communication can really boost your scores. Patients are engaged, and if they're engaged, you know they're listening. Walk about the agency and hear what staff relate to in terms of how they're communicating with patients as well as responding to requests for more information or to their needs. Also critical is walking with staff in the field and in the office to observe their interaction with patients, families, and between care partners. You know, when communication or engagement techniques are observed or felt to be less than optimal, it's critical to invest in staff training for motivational interviewing or the use of some of those chronic care management techniques. We know communication is so complex at the best of times, and this is largely due to just the complexity of communication to begin with. I grew up in a family of 9 children, and it was considered a coup to be able to get your point across. So in large, very complex situations with family and family members, it's critical to have those skills and to have a situation, ideal situation for communicating, teaching, and getting to the heart of matter. Your investment in clinician training, I can't stress enough. It will help build staff confidence as well as patient confidence, and ultimately will improve the patient's experience of care. Next slide, please. Another approach is to routinely consider your HHCAHPS in the context of your OASIS reports. So, for example, when looking at your composite measure, again, for specific care issues, consider M1510. This is, did the patient exhibit symptoms of heart failure? And the action taken is scored a number 4, patient education or other clinical intervention was taken. Is that consistent with for example, a 98% of the time process measure on the OASIS that we are teaching? If 98% of the time we're teaching, are our teaching methods effective? You know, teaching has taken on a whole other skill level, and we're not always prepared to really deliver on that. So I often find in my visits to observe teaching and to observe communication that we're not taking the time to chunk down the information. So to really chunk down how many steps will it take, for example, to teach patients the side effect of a medication. We often don't allow time for the patient to chew on the information. And then again, are we checking back with the patient to see what was retained and what might I do to improve my teaching techniques. So field observations of patient teaching and specific training on patient teaching is critical. Next slide. Agencies also report great success on their HHCAHPS when they've invested in chronic care management. And what I mean by that is not only do they have the education on chronic care management, but the agency has come out with a strong statement about this is our standard of practice. Many agencies are providing opportunities for certification. And really the crux of the matter with chronic care management is not so much the pathophysiology, it really is building staff confidence with communication and teaching techniques. It also helps to really build collaboration across provider communities for effective and consistent care approaches and care messaging. In many of the agencies where I instruct on chronic care management, I encourage them to train with care partners. So bring to the table and to the training sessions their physicians. I've had classes that have had physicians, physician practice staff, staff from the diabetes center, hospital case management staff, SNF, skilled nursing facility staff. We've had nurse practitioners, we've had CFOs in our class, as well as clinical support staff in our sessions. And something really fundamental happens there. We start speaking the same language and we improve consistency with our messaging. Use IT and EMR applications, and more I'm seeing as I move around the country a resurgence of pathways, but real specific alerts to patients when there are variances with objectives that have been set for their care. It really will allow time to make adjustments in care when care is being given. You know, HHCAHPS takes a commitment by leadership as well to think outside the box. So often we limit how we think about care issues from the perspective of agency day-to-day operations. What we're talking about here is really a dramatic shift in perspective that begins with decision processes that always consider care based on that STEEP acronym. So at this point, I want to thank you for allowing me to speak to you about my experiences today. And I believe I'm turning this over to Misty or Cindy. Thank you.
Thanks, Rita. We're going to go ahead with the next slides, and then Cindy will come back and entertain some Q&As. But I will throw in a plug. If you have questions, you can always put them into the chat or the Q&A box in the meantime. So taking the information that Rita has presented, which I thought was great insight, great information related to the HHCAHPS, and how do we take that the next level? She's giving you some great tips in implementation at an agency level. And so what I did is I took her 6 domains that she started with earlier in the presentation and kind of did a spin related to the cardiovascular. So thinking about it at an agency level, how could we integrate the pieces that will impact their HHCAHPS? So we'll kind of start right into clinical care. So with looking at the clinical care, we can take and integrate best practice evidence-based strategies from our cardiovascular health, you know, through our BPIPs, through the ABCSs, through the resources that we have out there. And by doing that, we are going to improve clinical outcomes. We're going to improve patient care. And as we talk about evidence-based practices and consistency through all of our disciplines talking about those practices, the patient will realize, as well as their family, that what we are doing and how we are trying to implement, or how it affects their care. I'm going to talk a little bit about action planning several times because I think that's significant. I think Rita kind of talked about that before, and especially when we're talking about person-centered care, we need to engage that patient. First place, we're not going to get anywhere with disease management if we aren't engaging that patient. And for them to be part of and to see the relevance of the clinical care in what we're doing in our care planning, we need them to be involved. And action planning is one of those measures, and I'll talk about that in just a minute. If we ask and we assist that patient with managing their blood pressure, cholesterol, and smoking, these are three of the critical areas that we can improve that patient's quality of life as well as their quantity of life. So again, taking those and really engaging that patient and understanding why we're doing that for their clinical care, we're going to make a difference in that domain. Now, the person and caregiver-centered experience and outcomes, that really takes a big focus on HCAHPS, because we can, how we impart what we are doing is for the benefit of the patient and for them to be involved. So we can display that we really care about that patient and their heart. We're trying to reduce heart attacks and strokes. You know, we care about that person and their family, and to be able to help teach them these strategies and work with them to reduce their risk. We can use that action planning I was talking about. We have lots of action tools. I have some slides at the end that will give you lots of references with links. So when we look at it with action planning and doing an action plan itself, it's really asking the patient what their goal is. Another point that Rita made earlier was communication. We need to listen, not do all the talking. So we need to listen what they want, which usually is something non-medical completely. Then we need to help them figure out an action plan to accomplish their goal. And obviously, we can tie in the medical components there. But in addition to that, we need to communicate that across all of our team members. So we're all focusing in on that patient's goal in their action planning. Rita also mentioned TeachBack. TeachBack is an excellent tool. It is really using that technique to see if we have taught that patient, not if the patient understood it, but did we teach it the right way, in the right format, in the right adult learning style that is compatible for that patient? Was it health literate? You know, was it in the right language that it needed to be in? Did I break it into pieces like she talked about, chunking and letting the patient chew on that information and then check back? So TeachBack is an essential component with especially disease management and with cardiovascular health. Another way is to change up how we do it. We do a lot of oral education, maybe some written education to supplement. But interactive and games and activities is a great way. While I know our time is very limited in seeing patients in the home, one of the new things that we're going to be including in our upcoming best practice packages, especially our focus best practice packages, is quick ideas that you can do for games or in education. And I'll give you an example of one. Simple is to take one of the weekly supermarket flyers in talking about diet and creating a planned a plate that the patient's going to do, or what foods are high in sodium or high in fat. Use a marker or a pen and let them put circles around good food choices and X's around bad food choices. And I'm going to use that activity in a few minutes when I talk about some underserved issues too. So those are some simple things, but you know what? We're going to provide some ideas to get staff started to think outside of the box. When we talk about safety, we usually think about falls, but if we can decrease that person's cardiovascular risk, that really is in keeping that patient safer. It's also keeping them home and reducing hospitalizations, emergent care, and falls. And improving the cardiovascular medications is really critical, because we have issues with patients with adherence. But most of the time when we really dive in and investigate, those adherence issues are things that we can resolve and work around, because we have to understand where that patient's coming from to help them to be adherent. Sometimes it's financial. I know that's usually where we look first, but there is a lot of reasons. And so here's another tip with medications that I've taught with HHCAHPS. Is you need to break that up, just like Rita talked about, chunking, chewing, and checking, but you even need to do that on individual visits. You need to lay out, have them pull out their medicines when we get there. We get the bottles, gives us a chance to check for reconciliation on every visit is most ideal. And then it gives us a chance to at least make sure that our frequency and our durations are correct. Then I might go on to teach about something else and then come back to the medicines in the middle of my visit. Now we talk about maybe the side effects, the reason that it's important for disease management. And then thirdly, prior to finishing up the visit, I want to come back again. And it's a chance for us to close the loop, making sure they understood. We can do a good teach back. Did they understand they're taking the meds correctly, why they're taking them, and how it's going to help prevent hospitalizations, heart attacks, strokes. So it's a chance for us to break that out. The other issue that we see a lot in home health is that we see a lot of medication teaching early in the episode, and we work our way down and we get ready for discharge. It's essential to really beef up our medication teaching towards the end of the episode as well, because we're getting these patients ready to be self-managers and to go into the community without home health. So we really want them to understand and are able to adhere going forward, and also that they're able to see the significance in continuing their medications. The other factor to keep in mind from HHCAHPS, most of the time, it's anywhere up to 60 days or around 60 days post-discharge. So the impression that we leave that patient with is really going to be important versus thinking back, 30 days, 40 days, 60 days prior, how we may have done a lot of that up front. Meds are so important. They should be carried through every single visit and the importance. But, really beefing that up, because we want to keep them out of the hospital and also out of the ED and actually even additional physician visits. So let's take a look at efficiency and cost. I think I actually covered this already in the first two bullets here. And avoiding the extra physician visits. What I mean here is that if we can keep the patient from having unnecessarily to go to the physician offices, well, that helps our partner, the physician, in getting clogged up seeing extra patients, but we've helped this patient to be able to manage their disease much better. And for them, that's not having to have extra transportation that they might have had to pay for. They have to get dressed and go out. That would be a burdensome to them. And also getting family members to take off from work to go with them or to come and help take that patient. So that really does help that patient as well as the physician. We need to create a team approach to cardiovascular health. It is not just about the nurses. And I'm going to talk about that in the next section with care coordination. It is the entire team. We need to be doing this together. So with that, I'll move into care coordination. It's essential that minimally that we're all taking vital signs, unless your state law prohibits that. So for home health agencies, the first thing I'm going to tell you that you need to look at your own policies and procedures. You need to look at your state regs and requirements for each of your disciplines. For therapy, the therapist should, unless it's prohibited by your state, the national associations for PTs, OTs, and speech encourage and recommend for disciplines to be taking vital signs. Therapists really need to know what the blood pressures are related to their plans of care and how the patient's responding anyway to exercises. So in a lot of cases, it's PT only or PT-OT only, and they're able to identify hypertension issues where nursing could be integrated or meds could be adjusted based upon reporting those elevated blood pressures. I will give a plug we have an upcoming webinar in January and with the underserved population networking call, and Misty Dyke is going to put that into the chat window for you, a link to get you there. But on January the 29th from 3 to 4 p.m., we are going to be having two physical therapists that are going to be presenting on those topics. And if I get back to the right page, I can find you that information. Sorry, I kind of lost my screens here. Our two speakers are Bud Langham. He's a physical therapist as well as the Chief Clinical Officer of Encompass Home Health and Hospice. And Ken Miller is also a physical therapist, and he's the clinical educator out of Catholic Home Health. So they will be presenting our first of several sessions that we're going to be doing related to leveraging therapists in all aspects, but this will be the first one. The next point that I have is reinforcing our cardiovascular teaching and tools. It's more efficient, and remember for HCAHPS, the more we go over the information, the patient is going to obviously learn it better, but it's going to stick into their memory more, that we are coordinating. We're all working around the same tools. It could be a zone tool. It could be a stoplight tool. It could be, monitoring their blood pressures and writing them down, and we're reinforcing, did you check your blood pressure? Did you write it onto the sheet? And it's a great way to show care coordination for us, and it shows that to our patients and our families. If we focus our teaching around the patient's goals and strategies, all of us, our home health aides included, if we're all privy to what that patient wants to do, then that helps us with our care. It helps the therapist integrate their home exercise programs, or helps the patient to use safety bars and safety measures to get in and out of the shower safely. And community population health is our last, is to educate clinicians on race, ethnic disparities. We will be having our next best practice package I'll put out is a blood pressure and smoking cessation. It's a focus package in February. But just to give you an update, in May, we have a cardiovascular health focus BPIP on the underserved population. But there's a lot of information within the package there to help you. Think about, can they afford those foods, like I explained with the ad before. That's a good chance to talk about foods that they're going to be, that's in season, that will be able to use. And obviously, if we are using culture-sensitive materials and we talk about their diet, then we really attune, and they will remember that we care about them and their culture. Okay, and now the next several slides I'm not going into detail on. I'm just going to let you know there are resources. Obviously, the Cardiovascular Health Part 1 and 2 BPIPs. I talked about action plans. There's several that are there. We'll have a new cardiovascular version coming up that you can even tie into cardiovascular their health, where they're able to choose what measures that they're going to work on. And the next slide, sorry, not clicking, there we go. Person-centered care, we have lots of information. Rita talked about motivational interviewing. That's really critical with disease management in trying to understand and to be able to motivate that patient. Remember, we're only in there a short time and going to be discharging that patient. Also, there's tools and resources on TeachBack. There are some zone tools. We even have Spanish versions, emergency care planning, what to do when symptoms occur, and team approach. There's information about using a self-hospitalization risk assessment where the patient's involved or the family is, and lots of other patient tools that are cardiovascular are perfect for this presentation. With care coordination, personal health records, and also discharge criteria, there's some great resources available for you. Obviously, we have our underserved population best practice package with tons of information that it's really a resource guide for you to pull where you're having problems working with patients, if it's health literacy, if it is underserved regions, et cetera. And I will do questions and send it back to Cindy for the rest of our presentation.
Thanks, Misty, and thank you both for you and Rita. We appreciate the content. It was really good. Now, as all of you are starting to formulate your questions, go ahead and use the chat window on the right if you'd like. And while you're thinking about your questions of what's going on, we're going to go ahead and turn it over to Crystal Welch, and then followed by Stacy Deslick for campaign updates, and then, of course, the fun facts about the HHCDR. So, Crystal?
Sure. Thank you, Cindy. I just really have 3 quick announcements I wanted to let everyone know about. I'll just begin with an announcement that the current participation with the HHQI campaign currently stands at 11,414 participants from 5,019 agencies. And of course, these agencies have access to all the free education and data resources that Misty just mentioned. Just 3 quick things. On December 1st, HHQI posted revised versions of the cardiovascular health best practice intervention packages, or the BPIPs that we refer to. And these packages were originally released in August and November, just a year ago, but the industry guidelines related to hypertension and cholesterol management were announced in December 2013, right after those came out. So the revised cardiovascular BPIPs are now available and include the most current information. And just another thing to remember is that we are excited to provide even more key patient tools, including the one I just mentioned, in Spanish. So look for the Spanish version to be coming out also before the first of the year. And we know many home health agencies need translated tools for patients and families. So each month, HHQI will be posting a Spanish version of some of our key patient tools. I know that this is good news for many agencies, and all of our tools are free, and they are public domain. So please feel free, if you can use them, feel free to customize them to your agency. If you want to add your own logo, you personalize them to meet your needs, don't worry, we do get asked if they can be altered, and yes, they are public domain, and you can add your agency logo to those, no problem. And then lastly, I just wanted to make everyone aware that if you like if you want to, or you like to bounce off your quality improvement questions, we have a chance for you to do that. And there's also a good chance that others want to join with you. So HHQI has a forum called Live Chat, and this is held once a month. The next live chat is going to be Thursday, January 9th at 2 p.m. Eastern Time. And this is just a perfect opportunity just to network with those around the nation, along with HHQI team members and other home health agencies around the nation. Live Chat is a casual online forum where you can just learn from each other, ask questions, bounce around some things. We have some polling questions that we pop up there, and of course share those best practices. So we hope that you will join us, and if you go to homehealthquality.org, you can actually set an email reminder so that you can remind yourself to join in on that live chat. homehealthquality.org, go to the network tab, next, push the live chat, and you will be able to set an email reminder. So there are some other announcements, but since we're short on time, I'd just like to encourage those just to visit homehealthquality.org, go to the news tab, click on the most recent edition of our Inside Edition December newsletter, and check us out. So with that, I'm just going to go ahead and turn it over to Stacy Deslick. Stacy?
All righty. Thank you so much, Crystal. I appreciate that. And thank you all for joining us today. I, too, will make my comments abbreviated since we're running short on time. So there is a polling question that's come up on your screen if you would like to answer it, about which data registry measure do you think was most abstracted, and then at the end of my little talk, I will let you know which one it was. So as we mentioned, and as Cindy mentioned at the beginning of this call, this portion of the webinar will include a basic overview and discussion of the happenings in the HHCDR, the Home Health Cardiovascular Data Registry, or what I call the registry for short because it's a mouthful.
The registry just closed for the first month back on December 14th, and the next month's data is now available for abstraction, so agencies can go ahead and abstract their next month. The reports for the previously abstracted data are currently in production, and we hope to, or we plan to have them available around the 23rd of the month along with all the other HHQI reports. When the reports become available, we'll be able to discuss how to interpret them and use them to improve the cardiovascular health of your patient population. So make sure to look for more about those reports in future CardioLand webinars. So for some highlights, kudos and shout outs with the registry. First, I'd like to congratulate the entire state of New Jersey for having the most home health agencies abstracting data this month. Wow. Way to go and get a jump on things. That's awesome. I'm sure next month other states will give you a run for your money, so keep up the great work and continue to involve more and more agencies. Now, I'd like to recognize two specific agencies for outstanding activity in the HHCDR. First is VNA of Somerset Hills Home Health from Somerset Hills, New Jersey. VNA of Somerset Hills was the first agency to close out a month of data in the registry. Now, they beat out several other agencies by only a few hours. It was really awesome to see such tremendous participation so quickly after the registry opened. So great job, and again, congratulations to VNA of Somerset Hills. Secondly, I'd like to recognize and give a shout out to HHCAHPS Resources from Arlington, Texas, for being the first agency to abstract and close out all 4 measures. Spectacular job. Again, next month, I fully expect to see more agencies abstracting all 4 measures, which will help to give a larger group for comparison for each of those measures. Again, congratulations to HHCAHPS Resources from Arlington, Texas for setting the bar high. Now, finally, the little fun fact from our polling question. Earlier, Cindy had put a little tidbit out there that we would have some fun facts. And so today's is about which measure was most abstracted. It looks like everybody has voted, and 25% of you were correct. It was the aspirin as appropriate measure. And following aspirin were blood pressure control and smoking, which were tied for second nearly. Smoking was a tiny bit behind, and cholesterol brought up the rear. So before I leave you today, I'd like to challenge all of you to select cholesterol, or better yet, select all 4 measures for abstraction this month. Let's see how much we can improve and increase participation in the registry. And that's all I have for you today, and I look forward to speaking with you next month. Cindy, I will pass it back to you.
Thanks, Stacy. And yeah, I was one of the not 25% on that one. I thought it was going to be blood pressure. So thank you for educating all of us. So let's go ahead and open the lines, Misty Dyke, if you don't mind, and see if there are any questions. I'm not seeing any questions in the window, and I just want to make sure that we do have a couple of minutes for maybe 1 or 2 questions. But this is your warning. We're preparing to unmute all the lines. Make sure that your line is currently muted, or else we're going to eavesdrop. Misty? So does anyone have any questions out there? Well, I think it was a really good, hello?
That was just me, Misty. I was letting you know that the lines are unmuted.
Oh, sorry about that.
But
we're not hearing any questions. I'm sorry, I'm talking over top of somebody. I apologize for that.
Can you hear me? This is Judy.
Hi, Judy. Yes, we can hear you. Is this Judy Miller?
Yes, it is, of course.
From New Jersey. Thank you for joining us today.
I know. Can you clarify the next chat date? Crystal, I think, said the 9th, and I think that's a Friday. The chat on the 8th, or is it on Wednesday?
Yes, you're correct. Misty Dyke, if you could, I think we did change those around. I think it would be a Thursday. Is that correct? So it would be the 8th?
Yeah, we've actually moved the January one. Normally that will be on the 2nd Thursday of every month. However, for January, we moved it to that Wednesday, so it's January 7th.
Oh, January 7th. Oh, my goodness, we're hopping all around. I apologize for that. I think I probably looked at a 2014 calendar, so I'm not in the 2015 frame of mind. But thank you very much, Judy, for catching that. So live chat will take place January 7th at 2 p.m. Eastern.
And while we have a moment, and now that we know that Judy is on the line, I'd like to talk to, just mention that each of you as home health agencies in this country, that is all 50 states and territories and District of Columbia, each of you now has access to a quality improvement expert in your state, free of charge through your QIN and QIOs. We mentioned this because this is a limited opportunity. This is something that in home health, we have not had this opportunity for the past 5 to 6 years, and now it's come back around. So we want to make sure that all of you are aware of this, that you do have experts, to the quality improvement experts in your state, such as Judy Miller, who was just on the line, and she is the lead for New Jersey. So I want to mention that you have this opportunity. Please take advantage of reaching out to your Quality Innovation Network, Quality Improvement Organization person who is representing your state. Now, we at HHQI, we're always here to help. But there's just a few of us, and this way you can have somebody in your state help with aligning what your projects are and how they can help with that. If you're not familiar with who is representing your state, that list is found under the data resources. You'll see a long list of network coordinators. Many states have multiple people, but if you look next to their name, the one that has the QIN, QIO insignia next to their name, that is the person that you'll want to reach out to for quality improvement assistance. And if you're not comfortable or can't figure it out, or you can't reach the list, whatever, or maybe you're contacting them and not able to reach them successfully, just contact us and we'll be glad to help you facilitate that call, at least to find out what the opportunities are and to make sure that you're not missing out on anything. So with that, we'll pause for one more time for if there's any questions. All right, hearing none, just a couple more updates. As you've heard already on the call today, the HHCDR is open. In the past month, we had greater than 500 episodes of care that were entered, data was entered into the registry. We want to thank you for that. Those are the go-getters because that was the first month the registry was open. So yay, give yourself a hand. But the registry is now open for the second month. Those of you that have already participated in the registry, you have probably reached your milestone number 2, if not number 3, when the reports are posted. And in a couple of weeks, if you download your report, you will have probably reached milestone 3. So keep that in mind. Those insignias, which will be a logo and a certificate, the links will be emailed to you within the coming weeks, and you'll be able to download these and be able to use them in your marketing as you choose. The next Cardiovascular Learning Action Network, the CardioLAN, will be on January 15th at 2 o'clock Eastern in the same location. Remember, we will send out the webinar or WebEx invite to those who are already registered. If you're not registered and you'd like to be, contact us and we'll be happy to show you how to do this. In the next meeting, the focus will be on immunizations, influenza, and how this impacts cardiovascular care. Remember, your cardiovascular patients are some of the highest risk patients that you care for, and being that we all know what's in the news right now, we felt that this was a very timely topic. We're very fortunate to have an immunization expert coming into the call to talk about this. So we want to invite all of you to mark your calendars for that. Now, the final thing I will just say is, as you were chunking, chewing, and checking, as we heard today, remember 'tis the season to enjoy not only your family, your friends, your coworkers, and of course, please take a couple of minutes and enjoy your patients and your caregivers because you know that they are enjoying you as well. So from all of us at HHQI to all of you across the country, we'd like to wish you a wonderful holiday season, and we wish you peace. Have a nice day, everyone. Bye-bye.